And the next thing is Addison Cushing, we talked enough. You guys know adrenal gland and cortex. What is another disease in adrenal gland? I did yesterday.
Pheochromocytoma.
What? Very good. Anybody else remember? I want you to add there on the bottom. And remember, adrenal gland question, you have Cushing, Addison, and the next one, phenochromoscytoma. And what happened here? Cushing, your blood pressure is high. Addison, your blood pressure is low. What happened in phenochromoscytoma? What is too much? High catecholamine. Write down the word catecholamine. They have too much of catecholamine. Where is the tumor? In the adrenal gland medulla. These two are cortex. And this one is medulla. Are we clear? And what happened to your patient with phenochromoscytoma? They have, it's a tumor producing catecholamine, and write down too much of epinephrine. And when you have too much of epinephrine, their blood pressure is very high. So phenochromoscytoma is hypertension. What do you do for your patient when you are admitting in phenochromoscytoma? Whenever your blood pressure is high, your priority is a blood pressure. And what room do you keep when your patient blood pressure is high? Quiet room, non-stimulating. Do you want to cut down the telephone? Yes. Do you want to cut down the visitors? Yes. A lot of visitors cause you a headache. A lot of telephone calls you what? More headache. You don't want to talk, but you're getting calls, right? So what do you do? Cut down the phone. Cut down the telephone. So remember, I just reviewed Cushing, Addison, phenochromoscytoma. They're all three diseases of what gland? Adrenal. What do you do, patient with phenochromoscytoma? Remember, blood pressure is high. Cushing, blood pressure is high. Addison, blood pressure is low. So what is your adrenal gland is maintaining? What is adrenal gland is maintaining? Your vital sign. Are you going to maintain the vital sign if you have adrenal gland problem? Yes. For phenochromoscytoma, very important. One question. What do you do when you're admitting patient? Keep them quiet room, non-stimulating room. And what do you control? Their blood pressure. Are we clear? And monitor their blood pressure. Lower the blood pressure. What is the treatment for phenochromoscytoma? There is a tumor. What do you do for tumors? You remove what gland? Adrenal gland. So what are you going to do? Surgery. And what is the name of surgery? Adrenalectomy. Connected, connected, connected. Now I'm going to move on respiratory question. Your patient has respiratory depression. Which patient will have respiratory depression? Write down on the top. You're giving morphine. You're giving pain medication. Sedation, over-sedated. Sedation depresses your respiration. So what do you stop? Right away, PCA pump. Patient control pump, right? PCA pump. Why? What is in PCA pump? Pain medication. Whether it's a morphine or what? It's a pain and pain medication. What do you do? Take out, stop anything with sedation. Any fluid they're getting can cause sedation. Number 5, give oxygen when their respiration is low. Your breathing, any question when you see patient has tachypnea, your breathing is going high, they're struggling for air. Are we clear? So you give oxygen. And that's important. And number 7, check circulation. If there is no pulse, and then you start the CPR. But first thing you do is, in your question for respiratory depression, what are your medications are? All your medications, sedation, your seizure medication, your sleeping pills, anxiety medication. Are we clear? Write down the word CNS depression. Any drug, and whenever they're saying they're taking CNS depression, that means you need to cut down that. No alcohol. Whenever you're taking CNS medication, no alcohol, because they depress more. You don't take that. So that covers here. I want you to move on the word allergies. Allergy caused by, underline the word foreign protein. Sometimes allergies means reaction, but they can be any foreign protein in the body can lead to. We all know urticaria, we all know itching. And underline the word administer the medication, antihistamine. What is your antihistamines are? Benadryl is your allergy medication are. And treat prophylactically, last line, by giving prophylactically antihistamine. Antihistamine, you treat them for airway first, then you continue with antihistamine. Then you're going to go hemolytic. What is acute hemolytic? Blood. How? Underline the word ABO, incompatibility of red blood cell. Can be caused by. Very important, blood transfusion. Hemolytic means blood transfusion. Are we clear? ABO, incompatibility, underline the word. Now they will have tachycardia. Underline the word hemoglobinuria. Very important. Whenever there is a blood reaction, they might throw the word hemoglobinuria. They're passing hemoglobin in the urine. And it affecting the kidney. Underline the word, the pain is in the back with blood transfusion. And they can go in collapse, renal failure, and cardiac arrest. So when you have hemolytic reaction, we all know allergies, rashes. Yeah, first thing is your airway you're looking for renal question, you're looking word hemoglobinuria, you're looking hypotension, they're going in a shock. And what do you do management? Stop, discontinue, change IV tubing, and also blood sample, serological test, urine because of the kidney. You got to collect urine specimen and add there. Also you can give diuretics. Insert Foley catheter, check urine output. Maybe patient need dialysis, and also give normal saline IV. When you stop blood, change the tubing and start with normal saline. Everyone should know the word back pain. Remember the word kidneys are damaging. Remember the word hemoglobinuria. Those three words are important. Anaphylactic reaction can also cause by infusion of IgA protein. We said the first thing is protein, foreign protein. Now write down IgA protein, and also who develop IgA antibodies. So IgA antibodies may be another word. And treatment is you look for anxiety, shock, you look cardiac arrest. Okay. Do not continue the transfusion. Maybe patient may need is epinephrine. Underline that word, 0.4 ml in 1 in 1,000 solution sub-Q. Underline that. So you must know is some of allergies question. Respiratory is number 1 your priority. Hemolytic means for the blood. Kidney is very important. Now I'm going to go Hirschsprung disease, that is in the peds. What is Hirschsprung disease is caused by, underline the word, absence of ganglion cell. There are absence of ganglion cell and in the child, and what is in absence where? Underline the word, diagnosed with rectal biopsy. So from the rectum area, their absence of ganglion cell, lower part of the intestine. So ganglion cell means there's no sensational there, no sensation. So if the BM comes, they're not able to pass. So it's like obstruction again. And so number 1, what is Hirschsprung disease? It's also called megacolon. But they don't give the word megacolon. So add there megacolon is another name for Hirschsprung disease. But they usually in the exam they give Hirschsprung disease. And that is, where does it start? From the rectum. How do you diagnose them? By rectal biopsy. What are you looking in biopsy? You're missing absence of ganglion cell. Now, what will happen in the child when they are born with this problem? Failure to pass meconium. If they give you a question, child is born, they're not able to pass meconium, what are you assessing? Heartspring disease. Could be that. And also ribbon-like stool, foul smelling, weight loss, write down the word, they lose a lot of weight. How do you treat them? I want you guys to add there. Number one, it's an obstruction. The BM, if they're coming like a little ribbon-like stool. And how do you treat them? Number one, they may try to give them normal saline enema. The other one was barium enema. Here, normal saline enema. They can increase the fiber here, but the other treatment is colostomy. There's no other way they can take out the BM. They have to do a temporary colostomy. Child gains 20 pounds, they have to wait. When child gets a little bigger, 20 pounds, they do the final surgery, and it's called pull-through surgery. Pull-through surgery. So everyone should know, this disease starts from where? From the rectum, rectal area. Are we clear? And so what is the child is having here? Ribbon-like stool. And what do they do treatment here? Colostomy. They can give enema just to try and see if that helps. And what kind of enema they give them? Normal saline. And also what they have to do, temporary colostomy. They got to open up. But after the child gains weight, then they do a complete surgery, and they give the name is pull-through surgery. And remember, no rectal temperature, because there is no sensation, no nerve because of ganglion cell, so no rectal temperature before surgery. And after the surgery, they're going to do is the pull-through surgery when the child has gained the weight. Are we okay? So everyone is okay. What is Hirschsprung disease? It's obstruction. Newborn baby did not pass the BM. What do you assess for Hirschsprung disease? And what is they are missing here? Ganglion cell. And what kind of BM they have? Ribbon-like stool. How do you treat them? By colostomy. How do you diagnose them? By rectal biopsy. Are we clear? They can also give them barium enema, barium swallow or barium enema for diagnosis, barium enema. But a lot of time, because they want to see the ganglion cell, they will do is what for them is rectal biopsy. So there are two ways. They can give barium enema just to see if they have any absorption there, and then they can do also is what is rectal biopsy, because biopsy can give them a good picture. Next is intussusception we did. Intussusception can be with the babies with cystic fibrosis and may cause fecal emesis. Write down the word vomiting. Sometime when you have obstruction, the BM is coming through the mouth, even an adult patient. They have obstruction, the BM is not going down here. And the adult patient, somebody has a bad obstruction, they are coming and the BM start coming through the mouth. Are we clear? So always when there is obstruction, do not give anything by mouth. Why? Because they have no peristalsis. The BM is not passing. Always remember, when there is obstruction, somebody comes in, you must keep the patient NPO, whether it's adult or a child. Check electrolytes because they are vomiting. And maybe suction, NG tube with the suction. These four answers very important. So remember, you got to think, where is the obstruction? What can you do? So the BM is not passing. Are you going to feed them? No. And what do you need to put? NG tube attached with the suction, taking out any fluid is building in the stomach. And then what are you going to do in intussusception? Answer barium enema. How does it work? We already wrote it down. Just highlight the word hydrostatic to reduce telescopic obstruction. And so there are two obstructions in the babies. One is called Hirschsprung disease, the other called intussusception. And we all should know for your Nclex. Next thing, omphalocele. What is omphalocele and gastrocious? Underline word gastrocious. There are two problems. And I want you to underline the word, where is the hernia? What is omphalocele and gastrocious? The organs are coming out. Where are the organs are coming out? Underline the word hernia of abdominal content. So abdominal content, write down near umbilical area. So from umbilical area, the intestine are pushing out. Are we clear? So what is hernia of abdominal content? Where? At umbilical ring. This is umbilical ring. So when the babies are born, this is the umbilical area, the herniation of intestinal content. So their intestines are coming out. I want you to write down on the top of omphalocele. Omphalocele has a sac. What is the meaning sac? All the intestine comes out, but they are covered with the bag. Are we clear? And gastrosseous has no sac. So what does it mean? They are loose intestine. That is dangerous. Which one is dangerous? Gastrosseous. What do you do for gastrosseous? The second one, because there is no sac, they must be covered with, it does say covered with the normal saline, and underline the word plastic wrap. Very important, you use the word plastic wrap for both of them, because you want them not to get stick and not to get dry. But gastrosseous, I want you to write down immediate surgery, because it's not good. Omphalocele, you can leave it few days. Even you push it back, because it's in a bag. They are safe. Intestines are safe. So they may push it back, may cover it, may put the NG tube suction, because you don't want the stomach filled up. When the stomach is big, they're pushing out. Are we clear? I want you to write down on the side suction, NG tube suction. Also prevent abdominal distension and cover it with normal saline, and also use what? Plastic wrap. That's important part. Everyone is okay? Gastrosseous and omphalocele, where is it? Right here is umbilical ring, and the organs are pushing out. Only the difference, gastrosseous is loose and has no bag. But first one, omphalocele, covered with what? With the sac. Everyone is okay? So what do they have to do? It's like a hernia. Are we clear? They're pushing out, so they have to do surgery. So some babies, they're born with that problem, and they have gastrosseous and omphalocele. Now, if they give you a question, hydrocele. What is hydrocele? The fluid in the scrotum area, in the male babies, and they may do repair. Some they subside. If they are not connected with the abdomen, they subside normally. But what do you do when there is a fluid? You can use ice, and you can elevate the scrotal area. Are we clear? So those two I've said. After surgery, same thing. Some babies, they're okay without surgery, but if it doesn't go away, they have to take out the fluid. And hydrocele, remember, it's in the male babies, and there were a lot of fluid in the scrotal area. So they're big, and the fluid absorption is not there, so they have to remove the fluid. And some, if they're not connected, there is no connection with peritoneum, it subsides itself. Next is no phenylalanine. I want you guys to write down PKU, phenylketonuria. That's another disease in the babies, PKU, and you guys can use the same space for PKU disease. And very important so far what we have done for your PEDS question. We have done celiac disease in the last package, so make sure you guys know your diseases. And now I will go over PKU. It's a phenylketonuria. So write down where it says phenylalanine, it's a phenylketonuria. That's the name of the disease. PKU level they check in the babies, and when they have PK means phenylalanine level, and what is normal? Write down 2 is normal. If it is higher than 2, maybe 6, 7, 8, and 10, that means PKU level is high. Are we clear? So when do you check PKU level? In newborn babies. Write down the word newborn babies. And they draw the blood. What is the test is called? Guthrie test. So write down the word Guthrie test. So what test we are doing here? Guthrie test. When do you, what the name of the test is a Guthrie test. So if they give you a question, Guthrie test, Guthrie, Guthrie test is done in the baby's heel. So you got to stick on the baby's heel to prevent nerve damage. And they draw the blood. When do you do this blood test in your question? Answer would be after mother give them enough protein. Enough protein means the mother start breastfeeding or artificial, that means the bottle feeding, whatever feeding you're giving. But don't do the blood right away when the babies are born. Babies must have ingested and received enough protein, maybe after 3 days, 2 days, but not right away. Are we clear? So what is it important? The body should have protein by milk and by breastfeeding or artificial feeding. What does why do we check PKU level? All 50 states, all newborn baby must be screened for PKU. Why? Because it damages the brain. Neurological problem and mental retardation. It can lead to the newborn babies mental retardation. So that's why we want to prevent that. So babies are born, they are checked for PKU, and if they have PKU positive, then you guys have in your notes, no meat, no dairy, no aspartame. What is aspartame? No artificial sweetener. That means no protein. You've got to restrict the protein. So write down the word, no protein, and no artificial sweetener. If they are positive. So what are you preventing to do this test PKU? By mental retardation. Are we clear? So this is very important, all these diseases for Nclex, Hirschsprung disease, intussusception, omphalocele, hydrocele. Everyone remember the word cystic fibrosis in intussusception. I want you guys to write down cystic fibrosis on this page, and I will write down a few things about where it says in intussusception CF. I will write down because I do want you guys remember cystic fibrosis for your Nclex. Celiac disease, these are all diseases are important. So I'm going to go cystic fibrosis. This is a disease in the babies, in the children. They're born with, and the problem is, number one, it's called exocrine gland. They're glands in the body, not your endocrine gland, exo, the body fluid. These glands are producing body fluid, and they're very thick. And it's a multi-system disease. Multi-system means it affects many systems. Number one, respiratory. There are risk for hypoxia, write down, and lung infection. They can get easily pneumonia. And so you prevent them from pneumonia and hypoxia. Write down the toys. They cannot breathe. They are children. Don't give a toys where they have to do exercise a lot. Any sit-down toys, they can play. Are we clear? So because of hypoxia, they're not getting enough oxygen, and they might say, 4 years old child with cystic fibrosis, what toy you can give? Keep that in mind because of hypoxia. Even they can go on a bike, you don't want them. Maybe coloring, something, sit-down work. Are we clear? So toys are important. What do you prevent for lung infection? Write down bronchodilator. Give them bronchodilator. CPT and fluids and antibiotic. That's important. So the number one problem, lungs. So write down there is a lungs problem. Number two problem they have in GI and lack of pancreatic enzyme. Pancreatic enzyme. And what food do you cut down? Fat. Are we clear? So remember, you cut down fat because pancreatic enzyme helps in digestion of fat. What do you give them? And you can increase protein and carb, but very important, cut down fat. Fat-soluble vitamin A, D, E, K. And with food, you give them pancreatic enzyme. In your question. Number 3, they're losing a lot of salt, integumentary system, skin. Mother says, when I kiss my baby, baby is very salty. What diagnosis you will go for? Cystic fibrosis. What do you increase here? You decrease fat, increase sodium. Number 4, when they get older, they're not able to produce children. It's called sterility. Because their semen is very thick. And the sperm doesn't reach, so it can lead to. So everyone, cystic fibrosis, multi-system disease, where does it affect? The lungs, GI, salt question, sterility question. You got to keep 4 together in your mind, because if you don't think that time, there may be a question about mother says baby is kissing and very salty, and maybe what diet you give, cystic fibrosis. So remember, they cannot digest fat. And what are they missing in the diet is pancreatic enzyme. Are we all right? So everyone, cystic fibrosis, these diseases we covered are important for us to know. I will move on to the next page. Second voided specimen underlined, good for ketones and glucose. So the second voided specimen is good. Never give potassium if your patient has oliguria and urea. Oliguria, low urine output, and urea means none. Means what? You don't pee, your potassium level is high, and write down renal failure, your potassium is high. Nephrotic syndrome. Now here you have very few things. I want to write down because you got to understand pathophysiology. If you don't understand, you will never pick up the correct answer. If you memorize these 2 lines, that's not enough. So I will write down nephrotic syndrome is only in the children. And nephrotic syndrome babies, there is an inflammatory process in the kidneys. So write down, it's a kidneys problem. What happened in the kidneys? Number 1, when you see the child, what would you see in the child? They have generalized edema. What is generalized? All over. Are we clear? They are rounded. You see them, they look, their face, their arm, the body, the stomach. They are all gaining a lot of weight. It's not a simple edema. It's called generalized edema. Ascites, right now they may have in the stomach fluid and scrotal area. So when you have edema, your questions are going to be, what do you do? Now, if they give you, you are a nurse, and what would you do with the child who is admitted with nephrotic? If you don't remember edema, what do you do for edema? Prevent skin breakdown. Write down the word prevent skin breakdown. What do you do? Maybe A-grade mattress. Maybe you're turning. Maybe monitor the skin. Are we clear? Generalized edema. The fluid, all over fluid. What are the risks for when you have a lot of fluid? Skin breakdown. Are we clear? See how you got to think. Number 2, they lose a lot of protein in the urine. And the word is called proteinuria. Proteinuria. Now when you lose a lot of protein in the urine, your protein less in the blood. So they use the word hypoalbuminemia. Hypoalbumin means protein. Anemia means in the blood. So now your protein is less in the blood. Are we clear? Whenever you are having ascites, you're losing a lot of protein. And also they're losing protein. So number 1, generalized edema. In generalized edema, remember the word is, what do they have here? Is the fluid all over. And also, I want you to underline, is number 4, is high cholesterol level. If you remember, like this, you will be able, this is pathophysiology. These are the symptoms. But what is it affecting here? Kidney. Now, what would you treatment? How do you treat them? Number 1, by giving steroids. There is no other treatment for nephrotic syndrome babies. They got to treat them by giving steroids. And what is the second thing they will give them? Diuretics. Are we clear? Now when you are giving steroids, now your diet comes. What do you monitor the baby with the steroids? You are turning into what? Cushing back again. So your questions are going to be monitored for infection. Are we clear? So steroids, I'm writing like here. Infection, very important. Sugar, very important. Fracture, because they have low calcium. And remember, you have low potassium. You can increase in the diet. And also diet question, very important. Because you have high cholesterol, lower cholesterol level, lower your sugar here, very important, sodium, you can reduce. You can give potassium, you can increase calcium, that's okay. But very important, you got to cut down the cholesterol, cut down the sugar, cut down. Remember, you're losing protein. Do not restrict protein here. Protein, the child should get enough protein. Continue protein, no restriction in the protein here. So I want you guys to add those wording. And nephrotic syndrome is a kidney problem. And what happened in the kidneys here, the child gains a lot of weight. And what do they have? Generalized edema. The urine is more frothy urine they have, and also they gain a lot of weight. So how do you treat nephrotic syndrome babies? Are by giving a steroid. So your questions are going to be on steroids. Now, only what you have here, proteinuria, dark color, frothy urine, and also corticosteroids you have, and generalized edema. But you have few things, but you got to keep a good picture. If you keep a good picture, you understand pathophysiology. Are we clear? So your questions are going to be, child is admitted with nephrotic syndrome, what would you monitor, or what would you assess, or what would you plan? Now you can pick up answer with the diet, skin care, weight, INOs, right? Because it's a kidney. You got to monitor hypertension, because when you retain fluid, you have blood pressure. But remember, you got to think around your patient, child, any question comes. So everyone, we are okay, nephrotic syndrome, we covered. Next is Western blot test for HIV, less than 18 months. Indicate only mother. So when you're looking in the babies or in the children less than 18 months, Western blot is not good. Underline the word P24 antigen will confirm HIV. So you want to check if the baby has HIV positive. So what test you will go for? P24. Are we clear? So that's another test for that. Now, very important, next line, HIV kids. And oral polio vaccine, varicella, and write down MMR, a live vaccine. Lot of question you see, don't give live vaccine. Who you don't give live vaccine? If they have immune system is low and they have HIV, write down immune low system. You can give immunization for pneumonia, regular, but do not give live vaccine. What are the live vaccine for you guys? I'm telling you, a lot of questions are coming, vaccination. I gave the other package, make sure you guys know. Don't get surprised, don't think you can guess your question, you got to be confirm your answer. And oral polio vaccine and varicella. Patients should wear gloves for care whenever you're dealing with HIV body fluid, so wear gloves. And not to kiss on their mouth because of the body fluid, not sharing eating utensils. But very important is oral polio vaccine, varicella, MMR, they're considered with the live vaccine. Next is hypotension. When your patient has underlying, check O2 sets because it causes constriction. So hypotension, whenever your patient has low blood pressure, check the O2 saturation. Antacids. You give your patient antacids when they are mechanically ventilated. What is mechanically ventilated? You're using ventilator. So what are the complications of mechanical ventilator patients are aspiration. I want you to write down the word aspiration. So when you have mechanical in your question, when you're using mechanical ventilator, you monitor patient for aspiration. Because they aspirate, they give them antacids. Second problem with mechanical ventilation is pneumothorax. Pneumothorax. What is a pneumothorax? Collapse of the lung. So there are questions. What do you monitor when you are giving mechanical ventilator? What do you give your patient? It says antacid because for patient aspiration. NG2, patient is less than 5.0, that means from a stomach. Aspiration should be checked as at least every 12 hours your patients are. So just remember the complication of mechanical ventilator is aspiration. That because they aspirate, they give them antacids to prevent from complications. Room air. Oxygen in room air is 21%. ARDS, acute respiratory distress. I want you, where it says the word ARDS, where you had in a Spiderman package, very important word, ARD is not primary. Write down the word secondary. When they're saying ARDS and DIC, both words, this is bleeding disorder. This is breathing disorder. Acute respiratory distress syndrome is secondary. It's not primary. That means patient did not have a lung problem. Are we clear? Pneumonia, COPD. But patient is going in respiratory distress. Why? There is something going on with your patient. What is going on with your patient? Maybe burn patient. Maybe renal failure. Maybe myocardial infarction. Patient is going in a respiratory distress. Patient may drown in the water. Patient swallowed a lot of water. And also aspiration and drowning. Burn patient. Remember, always your position is not going to be Fowler's. Why? Look at the reason. It's secondary. It's not because of the lung problem. If you have a burn patient, are you going to raise the head of the bed? What position is good for burn patient? What position would be better for your burn patient? What are you opening in a burn patient? What is the problem? Oxygenation. What do you open for burn patient? Hyperextending. Are you going to raise the head of the bed and patient head is going to be like that? What do you open? Airway. Are you going to put the positioning that maybe your patient is laying semi-Fowler's or in a back, maybe you're putting something under. What are you opening? Inhalation. You're smoking. You're getting in. What is the problem here? Getting air. Your position is going to be different. If you have your patient with fluid drowning, are you going to put them Fowler's or are you going to put them in prone? Prone position. Are we clear? Patient, when they say patient has acute respiratory distress, always remember there's something going on with the patient. Not always your answer. Maybe position as directed with the diagnosis. Maybe turning patient in a different position. Maybe Fowler's position if you don't have any other problem. But depending on your patient's problem. So not always your answer is going to be Fowler's. Next thing I want you to underline the word here with ARDS, dyspnea, retraction word. Air hunger, cyanosis, retraction. Write down the word nasal flaring in the babies. Something is wrong. Premature baby, neurological damage. Baby is going in respiratory distress because, not because of the lung, maybe because of something else going with the child. Are we clear? So just keep in mind, acute respiratory distress is secondary. What is acute respiratory distress means is hypoxia. Write down the word hypoxia. What do you do here? You do start oxygen. Positioning is important, whatever the reason is. Give oxygen. Write down the word ABG. You got to do ABG, not pulse oximetry. Are we clear? They are acutely breathing problem. How do we check acute breathing problem? By looking arterial blood gases. Are we clear? What test do you do before you do ABG?
Allen's test.
What is the test we call? Yeah, you're right. Well, everyone remember, we have done that. It's called Allen test. What is Allen test? You are checking the circulation in radial and ulnar artery. Make sure write down Allen test. How do you send the blood in Allen test? Take the heparin tube. You got to know, we are nurses. And what do you check before you draw the blood for Allen test? Radial and ulnar artery. You're looking, are they having a good circulation? Are we clear? And test is called Allen test, radial in the thumb side and ulnar artery, you're looking for the blood. And then what do? Your tube should be heparin tube. It doesn't clot the blood. Number 2, eyes. Put them in the eyes when you are sending the blood. And ulnar, this is ulna, U-L-N-A, ulna, radial and ulna. Put them in the eyes, the specimen. On your lab slit, if they ask you, see, your questions are very oriented questions. You are a nurse. Your doctor has ordered ABG. And if you don't know how you're going to do ABG, they're checking if you really know for ABG. So what test should be done before you take the blood? Allen test. How do you send the specimen of the blood in the eyes? What do you write on the lab slip? If patient is taking oxygen and you're giving 2-liter oxygen, you've got to write down on the lab slip there is a question. It says, is patient on oxygen? Yes. How many liter? You will say 2 liter. If you have patient in not on oxygen, you will circle the word no oxygen. That means patient is breathing in room air. Are we clear? So what is ABG? Is done for hypoxemia word. Hypoxia word. Hypoxemia means lack of oxygen in the blood. And you got to draw the blood. And ABG should be done. I do want to complete things because I want, if you don't know and you only memorize one word, there is no way we can do the Nclex. You got to know more than that knowledge so that can help you. So Allen test came many times in the exam. We did that. We did the room air oxygen, ARDS, PCWP, pulmonary capillary wedge pressure, normal 8 to 13. 18 to 20 consider high. Pulmonary embolism, chest pain, dyspnea, tachypnea. I want everyone to memorize in a different way. Because for your question, these are good in books, they arrange anyway, but in exam and when you are a nurse, I did already pulmonary embolism. And when your patient has pulmonary embolism, I said yesterday and I'm repeating here. What are the reasons for pulmonary embolism? Fat embolism. From fracture. Air embolism from is dialysis patient. DVT. And what is in DVT? Positive Homan sign. Everyone should know. Now your patient is, you prevent this patient. Are we clear? And your questions are going to be, how do you prevent pulmonary embolism? Now your question, your patient fell and patient has fracture. What are you assessing your patient fracture? Pulmonary embolism. What would be the sign of pulmonary embolism? Now you guys don't have here, but in the wording in the question in Nclex, number 1, petechia. Petechia means like a little dots you will see over the chest, sign of bleeding. Whenever they're saying ecchymosis, petechia word, or I'll write also ecchymosis. Whenever you have this word over chest and in shoulder, they didn't tell you pulmonary embolism. They said the patient fell, patient had a fracture, and you see ecchymosis on the shoulder and on the back of the shoulder, on the chest. What do? What are you monitoring? They didn't give you other symptom. What are you monitoring? Pulmonary embolism. So this is one of your early sign of pulmonary embolism. Are we clear? So what is early sign of pulmonary embolism? Petechia. And they ask you, what do you do when you see petechia? You have in your exam cram question, if you practice that, and there are two answers there. Raise the head of the bed and give oxygen with nasal cannula. Your best answer is raise the head, because you do not give nasal cannula. How do you give oxygen? By mask, because you want to give more oxygen. So your question, petechia is sign of what? Pulmonary embolism. I want you to write down like this. Hypoxia, lack of oxygen. You already know. Restlessness here, tachycardia, patient is having, chest pain, shortness of breath will go there. But then last thing you remember, they're going into shock. Low blood pressure, tachycardia, and tachypnea. This is the way I want you memorize, so you can picture the patient correctly. If you memorize 1 year cyanosis, chest pain, may not be there. And they're saying petechia came couple of times in the exam. Are we clear? So we've got to know couple of times, all your books, every time you see the question, petechia is early sign of what? Pulmonary embolism. Now what do you do for your patient? I want you guys write down the answers here. Is what answer? Raise the head of the bed. The first thing, oxygen 100% mask. Don't take what is the best mask for 100% oxygen? Non-breather mask. Write down like that. Burn patient, how much oxygen do you give? 100%. Are we clear? Any time when your patient is not getting oxygen, you don't want to give less. Same thing babies with the cyanotic baby. They have a death spell. They become blue. Give more oxygen. Are we clear? Number 3, you can give morphine for chest pain, for pain medication. And you can give also is next drug heparin. All your pulmonary embolism patients you're giving heparin. What is heparin is? Anticoagulant. It prevents, it does not dissolve the clot, prevents forming the clot. Make it clear. What is thrombolytic medication? I did yesterday in the other package. Thrombolytic medication is your streptokinase and TPA. Write down the word TPA. What is TPA is? TPA is also thrombolytic medication. What does thrombolytic medication does? Dissolve the clot. That is the difference. Anticoagulant prevent the clot, and this one is dissolving the clot. So what medication are you going to give in pulmonary embolism? Either heparin or streptokinase. Are we clear? And what do you do? The first thing, raise the head of the bed. Everyone should know, how do you prevent your patient in pulmonary embolism? Your DVT patient, your fat embolism patients are. That can lead to what is in clotting and is going to obstruct the airway. So that covers all your embolism question. Are we clear? And fat embolism, make sure you guys know. And what is the first sign of pulmonary embolism? Petechia. Are we clear? And if they give petechia, immediately you are treating as pulmonary embolism. Next, we all know chest pain, breathing problems, cyanosis, because the lungs, but they trick the question. And question may be only for that. Next is, we did that, pulmonary embolism and sudden chest pain, high potassium. Underline that word, don't need to memorize a lot, but remember, whenever your potassium level is high, second line, monitor for ICP. It can increase also your ICP. Pulmonary sarcoidosis. Sarcoidosis is damage of the lungs. It's not good. It's not a simple lung disease. And when your lungs are getting bad, you're going to go into what? Right side heart failure. That means the lungs are leading into what failure? Right side of the heart failure. Lungs are not, you have to work with your heart more, and now your heart is affected. I want you guys to add few things where you have sarcoidosis. I want you to to write down is, if you memorize and you will know some of the question, COPD patient. COPD patients are, emphysema is COPD. If they give you COPD or emphysema, the emphysema is COPD. Are we clear? Bronchitis is COPD. Asthma is COPD. So if they say, what do you monitor for your patient's complications with COPD? They're already having a breathing problem. I want you to write down the word is core pulmonary. Whenever they give you the word core pulmonary, core means heart. And what part of the heart is damaging? Right side. So we said, when you have pulmonary sarcoidosis, leading into what? Right side heart failure. COPD patient is also leading into what? Right side heart failure. Everyone is okay? COPD patient also leading into. Also, I want you to write down left ventricular failure. If your heart is left ventricular failure, is also leading to right side heart failure. So there are three conditions in your question. Monitor for core pulmonary word. Core pulmonary means the right side of the heart has been damaged. And in your question with COPD, emphysema patient, left ventricular and pulmonary sarcoidosis. Are we clear? I want you to put together. You find one here, you don't connect it. So that means your lungs are so bad that they're damaging, and what is the meaning core pulmonary? The heart has been damaged. Are we clear? So lungs, when your lungs and heart, they have to work together. Lungs are getting bad, your heart is getting bad. Are we clear? So that is the complication. I want you guys add on the side, what are the complications of COPD? Number one, core pulmonary. They are very common question for exam. Number two is polycythemia. They are increasing is the lab. Polycythemia. All their hematocrit and all very high. And respiratory failure. So they can go in core pulmonary, polycythemia, and respiratory failure. Your COPD patients are, right? Okay, so at least you add those answers there. NG2, you can irrigate with cola if your patient is at home and you are teaching how to flush the tube. You can use cola for clearing the patient's is NG2. Everyone must know for your exam, insertion of NG2, removing NG2, how to check residual, what is a normal residual, and you can continue feeding. Less than 100. Are we clear? And also, when do you check residual? Before feeding. All the time. Check it. Check the placement. How to check the placement. Those questions are in exam. And you have to drag and put them in the order. Everyone make sure we all know NG2. All right? When do you tell the patient to flex the head? When do you tell the patient to flex the head when you are inserting NG2?
Open oropharynx.
When the tube, very good, when the tube is going in oropharyngeal. When you're putting in the nose, then you go hyperextended. When the tube is coming right here, then you tell the patient what? Flex it. Are we clear? Sometimes you tell them swallow word. Sometimes you can give water, so some patients are very high risk to aspirate. You can give them the water, but you can talk to them to do swallow. And check, what is the normal pH of the stomach? What is the normal pH of the stomach?
4.5.
Less than 4 should be your pH. That means it's in the stomach. Are we clear? So less than 4, your tube is in the stomach. So some question, you can check the pH, you can aspirate. How do you confirm the tube? Is by X-ray. Are we clear? What is the tube? A G tube. Right here, right? That's a G tube. What is the word is called for G tube? PEG tube. Very good. What is the full name of PEG tube? What is the PEG tube is called? They didn't give you the PEG tube and they wrote it. Percutaneous, endoscopic, gastrostomy tube. Are we clear? Percutaneous. That means they're putting through the skin. You got the right word though. You got the right word. But let me tell you, sometimes they confuse you. They don't give the short word and they say, patient has percutaneous endoscopic gastrostomy tube. That's a G tube. Are we clear? And same thing with the G tube. Now, if you know G tube, you will easily, but sometimes they confuse you percutaneous. Are we clear? So how do you confirm percutaneous G tube? X-ray. Are we clear? X-ray. And do you change the dressing? Now, some believe you must clean the area. A lot of doctors believe leave it open, let it dry, don't need the dressing. But you got to monitor for infection because it can cause a lot of bad infection. You got to keep it clean. Sometimes it starts coming out the feeding through the tubing, and then it can cause irritation of the skin and infection. So you got to monitor. We already talked about yesterday positioning. I'll move on some question you guys have here. Is number 1, multiple choice. History and exam indicate 77 years old patient has digoxin toxicity. Which drugs are contraindicated? You already have digoxin toxicity. Now you do not, your answer is here is number D. So go ahead and highlight the word. And if you move on the other side of the page and you have A, B, C and highlight the word D is the best answer. Brilliant and verapamil increase serum digoxicity, possible causing more digoxin toxicity, so you do not give them. Okay? So just to know some of the other answer, so highlight that word. Next is question. Abruptio placenta. In abruptio placenta, blood, what is abruptio placenta? The blood is confined within the amniotic sac. Is it in amniotic sac, the bleeding? No. What is in amniotic sac? Amniotic fluid and the baby, okay? So, internal bleeding generally minimum. No. Blood loss may be concealed between the uterine wall and the placenta. And number D, there is always excessive external vaginal bleeding, which is the answer. Number C. What is number C? Is concealed between. Where is between? Uterine wall and placenta. Are we clear? So yesterday I showed you guys here, and let's see. This is the uterus and you have placenta here. Where is the normal placenta in your question? In fundus, in the fundus area. This is abruptio placenta. This is placenta previa. Are we clear? Now placenta previa, the blood is coming out. Remember, this one, lot of time the blood is not coming down here, but the placenta is separating and the blood is staying here between what wall? Uterine wall and placental wall. Are you clear? So that is why what happened to the mother here, the abdomen become hard. Are we clear? Like a bowl. Do you have abdomen hard on this one? No, because there may be. So don't think all the time there is a blood. She's bleeding. There is a pain. But remember, blood may be staying in the back here. And that's why the word is called concealed. Concealed, the blood is collecting back in the abdomen, in the area between the placenta and uterine wall. So number C is the answer. Underline in answer on this page. C is the best answer. Placenta previa, most correctly placenta previa is premature separation of placenta, and the blood loss is either is apparent or concealed. Now they wrote wrong here. Placenta is not a placenta previa but abruptio placenta. Are we clear? So in abruptio placenta is concealed, may not be coming out, may not be apparent blood loss. So your answer is number C is the correct answer. Let's move to the next page. Patient, geriatric patient, that's a good question. You are working in a nursing home. Geriatric patient has OBS, organic brain syndrome, or dementia. Organic brain syndrome and dementia is common in older people. Are we clear? We are getting dementia. And not able to make a rational decision regarding an emergency care. In this situation, you are using to permit you to legal render care. And Good Samaritan law, standard of care. Number C, implied consent. Now, when your patient has confusion and O, organic brain syndrome, number C is the answer. Is consent is called, because they are saying, may not be very alert, but they're giving you some permission, so the word is called implied consent. Let's go in the answer. Underline the word. Implied consent means patient most likely found in distress, and therefore you are within the law to treat the person who is unable to make a decision about his or her care, who is in emergency. Are we clear? So in emergency, you are taking what consent? Implied consent. Are we clear? So that may be in your consent question. Next is, so the best answer is that. Now skip all the line, then you go, and the bottom, it says Good Samaritan law. What is in a Good Samaritan law? We got to know. Line 2, in other words, if nurse step an accident scene and provide care, the nurse will not be held liable, underline that word, for their action if the care was provided in what? Good faith. Very important wording. And according to the practice standard. So you don't get lawsuit. Are we clear? Why? Because you have done your job, how? In a good faith and a practice standard in your knowledge. So you're not getting no lawsuit. But if you take a money and you're working for somebody and you're saying, oh, well, I can do that, but I can charge this, and then you are making a lawsuit here, then you're liable for lawsuits. Are we clear? But you walk in, you do the best of your knowledge, you're doing in what faith? Good faith. That is your answer. Good faith. I'm not giving you guys break. Are you okay? Because I'm stopping at 3 o'clock. Or you want to take a break? Are we okay? If anybody needs to, just step out and come back. So I want to finish some more, then we will stop. So everyone, what is a Good Samaritan law? Is you are doing, you are not, will not be held liable. That's your answer. If you are giving care in a good faith and a practice of standard. And add there, don't charge money, don't get paid. You are not doing as a job, you're doing in a good faith. Are we clear? So that's your question. Now, that is very important. Number B, what is a standard of care? They give you an exam question. A standard of care are established guideline for the nurse and healthcare provider is safe, underline the word, underline established guideline. There is a guideline. And safe and effective nursing care. So if we have a lawsuit, we go to the court, what are they going to look for? Standard of care. And they're going to ask, what is your standard of care? I've been in a court a couple of times, and the patient fell and patient had a fracture. So your question is, what is your standard of care to prevent your patient to fall? Well, this is my procedure. This is the standard of care. We get restraint order. This is what you apply. This is what you have done. So you have making a standard of care for your patient. And if you don't follow that, then you're breaking what? So as a nurse, what do we need to follow? Standard of care. If you break it, then you are liable for your lawsuits. Are we okay? These are very important wording because those are in the exam. Implied consent is, we already talked about. Number D, what is implied consent when you're taking an emergency, right? So number D, let's go informed consent. What is informed consent? Physician described the procedure that to be performed. Who explained for the procedure? The doctor. And including, underline the word explanation. You explain. What do you explain? Benefit and risk. What is the advantage and what is disadvantage? Are we clear? What can happen wrong? What are you doing now? They must know in advance. If you don't tell, and patient has the problem, patient said, nobody told me. So what do you have to list there? Advantage and disadvantage, benefits and is the risk. Next line, the patient is informed about the procedure and in the best answer and try technique with the answer. I want you guys add there. Yesterday I said word, so you guys can add competent. When your patient sign the consent, they must be competent. Write down the word that they understand. And where do you see competent patient? In the doctor's note. And number 2, no drugs. Patient should be not influenced of any drug, and they cannot make the decision, like sleeping pill, agitation medication. And number 3, language. Very important. We are multicultural people. People don't understand the meaning, what you're telling them. Don't go in your medical terminology when you're explaining. You got to go more simple. And you got to tell them the benefits and the disadvantage. Are we clear? So competency is very important, and who will get the consent signed is actually who is responsible for the consents are and explaining the physician. Always remember, that's a physician. But we do help a lot of time to get the consent. And who explain about the procedure? The doctor. Are we clear? Now, so very important these things. Next question, I'll move on, is person is holding his neck. When somebody is holding his neck, what does it mean? Choking, right? And if somebody cough, what does it mean? They're okay. If they can talk, they're okay. Don't start CPR, don't start Heimlich maneuver. So underline the word number A. Ask them to cough. If patient is coughing, they're okay. Write down talk on the side. If they're talking, they're okay. So neck means you're holding, they're having a problem. Maybe they're about to choke and they feel something funny, but they are coughing. That means they're okay. Are we okay? Next is number 2, and before you start CPR, what do you ask? Are you okay? Right? Don't just say patient is unresponsive, I start CPR and there is a question, check are you okay, and you miss that and you start CPR. They're looking what you go with the step. Are we clear? Same thing with fire question. Now patient is Alzheimer. What is Alzheimer? Patients are wanderer. Are we clear? They're mentally very confused. They don't know where they are. They walk around, they're wanderer. To protect his safety, what do? Don't restrain. Number 1, alarm on the door. All Alzheimer patients should be in where? Alzheimer unit. Alzheimer unit should have on the door alarm, and you put it on their wrist. When they're leaving, the alarm will go on. They can't leave. Don't pick up and say, Alzheimer patient, what do? Patient is walking around, you put a restraint. Get the order for restraint. Never restrain them. Put them in a proper placing. What will happen? Their risk for leaving the building, and they can die outside. They will never be able to come back. So very important, we are legal, responsible when you have. See, a lot of time they place in a wrong. When I was the DON, and I have about 6, 7 doors in my building. And I used to take patients, and when the patient comes in and found out they have been Alzheimer. And I have a main street. Somebody can be killed when they go out. My biggest concern, I cannot tie them, I cannot keep track, they're not in the right place. I want them to go in an Alzheimer unit because you're taking a liability. Now, you do want patient to come in your building, you want to keep the patient, but you got to put them in a proper placing because you cannot apply restraint and they're not going to sit down. Alzheimer patient, they're walking around, they're getting very confused, and safety is number 1. Next is patient, so put the alarm on the door and no restraint in your question. Let them walk around. If you're going to put and tied up, they will get more agitated. So they need to walk around. Next is when teaching a patient about urinary catheter, what is most important thing are? Wear a sterile glove or clean the urethra with bedtime. Number B, you don't need to wear, they have a catheter, you're inserting a catheter, then it's okay, but you're already patient teaching about urinary catheter care. What do? Wash. What do? Peri-wash. What do? Cleaning. Very important, but not as sterile gloves. A woman who is going for pap smear most important to follow up on before pap smear is performed is answer. Let's go on the next page. It says, is A, just started menstruation period, and number B, last pap smear was abnormal, never had sex before, forgot the choice. Now if you go in the answer, is the best answer, there are thought and rational. The person is holding the neck, those goes on there, and this is with this one. But there is, if you turn around the page on the other side, these are all the answer, what I did. So turn around the page, and I want you to highlight on the other page, it says, I just started menstruation is very heavy, is the best answer. The best time to obtain pap smear is 2 weeks after the first day of last menstrual cycle. So your answer is, I just had a period. Number 1, you don't do the pap smear, because when do you do the pap smear? After the menstruation period. Are we clear? So highlight the word on the next page on that. All right. Now next is question on the same page. So now we turn. These are all your answers, what I have done. So you guys can read later, but you already got the answer. Now let's go question. Alzheimer patient, incontinent of urine during nighttime. Any question nighttime? You are getting up too many times. What do? You limit the fluids during evening time. Number B, nocturia. Nocturia, nighttime pee, patient is going always. What do you restrict the fluid? Not drink nighttime. Okay. So, any patients, you or anybody, cut down less in the night. Number 2, patient who has hysterectomy, surgery. Observed nursing care include, or nursing care include, vaginal bleeding, urine output, and number C, vital sign. Number C, surgery, lost blood. Yes, it's okay, you need to know what is vaginal bleeding, but what do you do all surgery patients? Check the vital sign, so you know whether they're bleeding or not. What is the complication of hysterectomy patients are, or abdominal surgery? DVT, write down DVT on the top. Any question when you see in your test, patient has DVT, question, hysterectomy, if patient has C-section, patient has abdominal surgery, what do you prevent them from DVT? Are we clear? Risk of DVT. So what do you do? Early ambulation. Are we clear? Have them get up from the bed. See, the questions are going to be not your straight question. What is DVT? What are you teaching? They want to know if you know what is DVT and where the DVT comes. So that would be your answer. Number 3 is dilantin prescribed to the patient. Instruction to patient include is number A is the answer. Reticular count. It causes dilantin aplastic anemia. So check their blood cells. Number 4, ECG, a straight line. They gave in the exam. I gave you guys EKG picture, and you should know which one you start the CPR on there. But if there is a straight line, you're not starting CPR, but what do? Check the patient first. Maybe the leads are not there, patient is already gone, or maybe the leads are bad. Sometime when the leads comes off, you're showing the straight line. So you will not start CPR, you will not go IV fluid. Next is number 5. Superficial 15% and 20% partial burn. If the fluid is adequate, what are you going to see? Fluid means urine output, number A. So burn patient, how do you know your fluid? INO. Check and what is burn patient? Guys, I want you add there, what do you monitor for your patient in burn? Shifting of fluid. Write down the word. Remember the word shifting of fluid. And where does it shift? From intravascular to interstitial. So it's going from the blood vessel to interstitial. And that is why their urine output is low. And they are having edema. And always write down the word when your urine output is getting low because shifting of fluid, hypovolemic shock. They're going in hypovolemic shock, your burn patient. And also write down, you must have Foley catheter, check INO. And they have less urine output and their body is retaining fluid. And also write down, monitor for hyperkalemia, because the fluid is shifting inside. Are we clear? So in your question, what do you monitor patient who is burnt? Number one, hypovolemic shock, right? What is second thing you keep it in mind? Your potassium level, you got to check. Because potassium level, because the fluid is retaining, and their low urine output. But once you start fluid, after 24 hours, they can spill all the fluid, and that's why you got to monitor INO and the fluid. How do you monitor body fluid in the body in a burn patient? And we have done CVP line, central venous pressure line. CVP line. What is a normal CVP? You guys have done in the last package. 3 to 11. 3 less than 3, they need fluid. More than 11, they don't need fluid because they're more fluid. So in your question, what is CVP line? You are monitoring, write down the word blood volume and write down the word fluid. What is, the blood is full of fluid. So what do you assess when you're having a patient burn? You got to see accurate INO. Accurate fluid. How do you give fluid accurately? By putting a central venous pressure line. Are we clear? Now, if they say your patient CVP line is 3, you've got to notify patient need fluid. If it is more than 11, patient don't need the fluid. So very important, CVP line, hypovolemic shock, potassium, and also remember is hypoxia word. They need oxygen, 100%. You're going to give oxygen to your burn patient. And this is the way if you are thinking for your patient. What shot are you going to give for pain? What do you give for pain? Morphine for pain, not PO, but IV morphine. There is a solution and linger lactate. They give them IV and they calculate with part volume hydration, part calculation by part fluid. Part fluid. And that is in your exam cram book. Some books you have part formula. It's called part formula for fluid. That is used for burn patients. So write down that. Hypovolemia, this very important. And also another complication, ulcer. What ulcer? Curling ulcer. Very good. Curling ulcer. Are there risk for infection? Yes. What room are you going to choose for burn patient? Reverse isolation. Are we clear? So you guys have some knowledge collected. Now question was in burn, and that's what we did on there. So what do you monitor for fluid? Urine output. Are we clear? What is your normal urine output? 30 to 40 ml per hour. If it is less, that means your body fluid is not enough. I will just finish another 2 more questions. Yeah. Got it? Curling ulcer and infection. What do you use on burn patient? Everyone remember the word is called cradle. Goes over the bed. The cradle, you get the bed sheet over the cradle and patient is laying inside. Next question, I will finish in a minute. 1 more question. 2 questions I'll give you. 20 weeks pregnant woman. 20 weeks pregnant woman, most concerned. Wrong answer. What is the wrong answer? Number C. Fluid draining from the breast. Now, cheeks are okay. Uterus is a symphysis pubis is okay. Breast enlargement, but coming out the milk or coming out the fluid 20 weeks, that's not normal. Are we clear? Next is sterile technique is very important. Broken when? are A. Any fluid goes on your sterile technique. Supplies are wet, they're contaminated. You drop the fluid, wet word, contamination. Don't pick up that. So that covers here. Number 8, the metal piece is embedded in left eye. Anything goes embedded inside the eye, what do? Put the number B, you don't put pressure. Pressure, the thing will go inside more. Number B, dressing, or you can use, sometimes they use the word cup, small cup, and then cover. And you can cover both eyes, but don't do a pressure. Loose dressing would be good. Next is cerebral angiogram. Anytime you do after procedure, number A, encourage fluid. Number 10 is use clean and non-sterile glove care is appropriate. Is it use clean non-sterile glove care is appropriate when you're washing the genital area? What glove do you take? Non-sterile is okay? Yes. So yes is the answer. When you're doing pericare, washing the tubing, you can wear the regular glove, unless you're doing the sterile. So these are some of the answer. And you guys have the next page, repeat answer. We have few more pages left. I will do it the next week on Tuesday. Afternoon, I will do whatever you guys need the help, okay? Spider-Man or whatever you need.